Today's lecture will be about common gynecological operations. There are many gynecological operations that have been mentioned in previous lectures. For example, the anterior-posterior colporaphy in the lecture of prolapse, colposcopy procedure in the lecture of CA cervix and preneoplastic lesions. And so I'll just go of a few procedures that may have been mentioned briefly. For example, in this lecture, I'll talk about dilatation and curettage, myomectomy, hysterectomy, laparoscopy, and hysteroscopy. Gynecological procedures nowadays are becoming less invasive and safer, and a faster patient recovery time, especially with laparoscopic surgery and the more advanced robotic surgery. The incisions are becoming smaller. Previously, there was a saying that the bigger the surgeon, the bigger the incision. Now this is not true. The incisions are becoming smaller and the surgeon may not even need to touch the patient. Robotic surgery has not been introduced yet in our country, but hopefully in the near future it will be introduced in the field of gynecology.
العفو دكتورة، بس السلايدات ما تتحرك.
تمام. هسه طالع سلايد مال يعني
أول سلايد.
ها. إذا هيك على
هذا
أوكي تمام. With the first procedure is dilatation and curettage, where there will be a surgical evacuation of the contents of the uterus or taking a sample from the endometrium, which could be done under general anesthesia, under regional anesthesia, sometimes with a paracervical block or IV station. The cervix could be dilated iatrogenically using dilators, or it is prepared, for example, in cases of termination of pregnancy by cervical ripening agents. Here are the instruments used for dilatation and curettage. Inshallah, min salon saf sadis, we will demonstrate the instrument for you. First, we will use a Cosco speculum to introduce it vaginally, and then we will use a vollicellum forceps for holding the cervix to bring it into alignment with the uterus. Then, if the cervix is not dilated and we want to introduce the curettes and the sponge, we will need a certain diameter. So we will start with dilators from the thinnest dilator up to the largest, or up to the one that will is enough for introducing the our surgical instruments. Here you can see that we position the patient. واضح الفيديو يا جماعة؟
إيه دكتورة واضح.
Here we position this is a video from the internet. We position the patient in lithotomy position. We introduce a Cosco speculum, and then we start to dilate the cervix to create a tunnel so that the internal and the external are opened, and then we introduce the instruments. This procedure, dilatation, is done even with hysteroscopy in order to have access to the endometrial cavity. For example, if this is a retained piece, it will be removed by a sponge. If it is a polyp, it can be removed during hysteroscopy by a resectoscope. If we do endometrial ablation, it can be done through this procedure. But here, this is about curettage, where we take either a biopsy of the endometrium or we evacuate the contents of the uterus. The curettage could be diagnostic, for example, in women who present with abnormal uterine bleeding, or who, for example, have multiple uterine pathology, for example, multiple uterine fibroids, or when we want to do a vaginal hysterectomy for prosodentia. We have to exclude a coexistent malignancy, even if she does not have an abnormal uterine bleeding, in order to decide on the line of surgical management. Also to diagnose malignancy. For example, if a lady presents after the age of 45 with an endometrial thickness of more than 5 mm or 4 mm, and she's not on hormone replacement therapy and she has abnormal bleeding, I just want to check that she's not a case of endometrial cancer or the simpler endometrial hyperplasia. Okay, if she's endometrial hyperplasia, does it have atypia or not? If it doesn't have atypia and she has menorrhagia, I can use a Mirena. However, if she has atypia, do you think it is wise to use a Mirena, which is the levonorgestrel intrauterine device, to control bleeding? If she has, for example, complex hyperplasia with atypia. سؤال لكم.
دكتورة يمكن هنا الريسك راح يصير عالي، فما أقدر أخاطر أنه بالمارينا هنا.
Yes. Risk of what?
Risk
Very
of,
good.
of malignancy.
There's a high risk of this hyperplasia with atypia progressing to an endometrial cancer, and that's why it will be worrisome to use an intrauterine device or even to do endometrial ablation. Now the guidelines are recommending to do to give an intrauterine Mirena, to use a Mirena for women with hyperplasia with atypia, but with follow-up, with careful follow-up, and it should be done for dedicated patients, for those who follow up. But actually, it is better recommended for those with atypia to have a hysterectomy rather than a conservative management. طبعا تدخل بها الريسك أيضا الفامily history, condition of the patient. A therapeutic curettage can be done for those who have, for example, a missed miscarriage, a missed miscarriage, and we want to remove the gestational product. We will go for dilatation and curettage previously. Nowadays, we're going for medical termination, and if the abortion is incomplete, we will go for evacuation of retained piece of conception. It can be done for removal of a polyp or submucosal fibroid, but actually I don't recommend that much to use dilatation and curettage because it will be a blind procedure. It is better to do it during hysteroscopy in order to see exactly how many lesions there are and remove them. Therapeutic curettage in our hospital, we can do it also for removal of an intrauterine device that has a missed thread. It's inside the endometrial cavity, however we cannot find the thread, or it's probably misplaced, and that's why we try to remove it. In our hospital we don't have a hysteroscope. It is easier to be removed under hysteroscopic guidance, but we are trying to do whatever we can to help the patients not to complicate their condition, so we remove them with dilatation and curettage. It is mostly successful, but sometimes if the device is deeply embedded in the endometrial wall, it cannot be removed. What are the complications that may happen during dilatation and curettage? There may be perforation of the uterus. طبعا rupture هذه long-term complication. There may be a perforation of the uterus. As you can see, I'm dealing with sharp instruments. And for those who are not experienced or who do not do the technique well, these sharp instruments may penetrate and perforate the uterine wall. Okay, a perforation happened. That's not a big problem because it is a complication. But the problem is if you do not notice that perforation and you will continue with the sponging and the curettage, and probably, around the uterus, we have the bladder and we have the bowel. So if you're not careful enough and if you do not detect that perforation, you can go into perforating even bowel loops if the depth of your endometrial cavity is missed. The patient may present with bleeding, probably due to injury, and even perforation may present with bleeding. If the perforation is it's not associated with heavy bleeding, how do we manage it? And if it's associated with heavy bleeding, how do we manage it? Do you have an idea? Okay, I'll tell you. If the perforation is not associated with bleeding and the patient is vitally stable, I will observe the patient and probably it's just a wound. It will heal itself with time. However, if the perforation is associated with bleeding, I will need to do a laparotomy or laparoscopy for repair of the defect that happened to the uterine wall. There may be an infection of the endometrium, which is later on associated with a tubal blockage and secondary infertility. That's why it is recommended for women with secondary infertility who have previously had a cesarean or who had previously had acute dilatation, a curettage or evacuation of retained piece of conception. It is recommended that they have a hysterosalpingogram to assess tubal patency because the tubes may be blocked. Rupture of the uterus is a long-term complication. Why? Because if I do perforation, even if I repair it or if I don't repair it, it does not need a repair. It will be a weak point in the wall of the uterus, in the myometrium, that may present a risk for rupture uterus in the future and even a risk of morbid placental adherence and Asherman syndrome. There may be cervical injury during a cervical tear or perforating the cervix, creating a false canal during work, and even psychologically, especially for women with missed miscarriages, it is a psychological trauma for them, and these patients need care and counseling. أحد عنده سؤال regarding dilatation and curettage? Another common gynecological procedure is myomectomy, which you all know is removal of leiomyomas from the wall of the uterus. Myomectomy can be done, just myomectomy, we remove, or we can do it during hysterectomy. These fibroids could be removed, as I said, per se, if the patient has not completed her family, wants to retain her fertility, or simply does not want a hysterectomy. She may have completed her family, but she may relate her femininity with the presence of the uterus, and she may get depressed if we remove the uterus. So we can go for a myomectomy. The myomectomy, if it's an intramural or subserosal fibroid, it can be easily removed either laparoscopically or laparotomy. However, if it's a submucosal fibroid, how do you think we can remove it? If the fibroid is submucosal and it's impinging on the endometrial cavity, do you have an idea?
Hysteroscope.
Thank you very much. Tamam. Here you can see removal of multiple uterine fibroids. Not all myomectomies are end with hysterectomy. However, we have to counsel the patient. For every patient undergoing a myomectomy, the consent should be a myomectomy plus minus a hysterectomy. I will show you a video. You can see that sometimes the defect left by the fibroid in the wall of the uterus is too large. The bleeding may not be controlled, and we may end with a hysterectomy. But hopefully, we will just need a myomectomy. And as you can see, for example, for this uterus, we have multiple uterine fibroids. When we remove them, there will be, at the beginning, a disconfiguration or disfiguration of the uterus. The uterus will look not like a normal uterus. However, with time, it will go back to its normal shape. The site of the myomectomy scars will be a weak point with a risk of rupture uterus in the future if she gets pregnant, and also a risk of morbid placental adherence. The uterus, the site of the incision in the uterus here, it will be a site for adhesion for the omentum and for the bowel, especially the omentum and the bowel. إذا anterior طبعا نتوقع البلادر هنا, but posterior or fundal, we expect either the omentum or the bowel. So sometimes what do? When we remove the fibroid, when we do a myomectomy, we intentionally نتقصد إنه نجيب omentum ونخيطه على الانسجن. Why? Because the omental adhesion is easily divided in the future if you want to do a hysterectomy. However, if the bowel is adherent and we try to do adhesiolysis, we may end with bowel injury. Sometimes there may be a fibroid discovered during cesarean. Our hands may itch us to remove that fibroid. Actually, it is not advisable to do a myomectomy during cesarean, and it's not recommended because we will end with severe bleeding, and that may end with hysterectomy. And you all know what happens to fibroids during pregnancy.
They grow responding to the hormones.
Yes, they grow, and sometimes they grow to a degree where red degeneration happens. You can see here is an MRI image of the uterus, a pregnant uterus, the feet, presentation, the spine, this is the skull, and here fibroid, and you can see these dark areas, and also this is another yes, this is the fibroid, and you can see that these dark spaces represent areas of red degeneration of the fibroid. Do you think how do you think the patient will present when they have red degeneration of the fibroid during pregnancy?
Acute pain.
Why? Very good.
Because there is a bleeding inside the capsule.
لا مو bleeding.
It's limited area.
بالعكس هي red degeneration يصير ischemia. That's why that's the cause of pain. Now you can see this video is of an Indian, I think an Indian doctor doing a myomectomy.
Once the uterine.
Here they did a uterine incision. This is the fundus of the uterus. Here is the right tube, and from this side, this is the left side. They are this instrument is used to just like an anchor to anchor the uterus and to anchor the fibroid, to hold to the fibroid, so that we can apply force to the myometrium. And as you can see, the fibroid is clearly separated from the wall of the uterus with this white glistening appearance. However, if the patient takes gonadotropin releasing hormone, مثلا إذا تشوفون هاي الفايبرويد مالته كلش كبير، ممكن تنتهي بستركتومي، فممكن اختار انه انطيها GnRH 6 شهور قبل لا اسوي الاوبريشن to decrease the size of the fibroid. But actually, this very nice line of demarcation between the fibroid and the wall of the uterus will disappear. فما راح اعرف ايش قد راح اشيل. هل will I be removing the walls of the myoma or the layers, all of it, or will I be taking some layers of the endometrium? Here you can see the fibroid will be removed. There will be a big defect left in the myometrium. هنا they are removing يعني separation of the anchoring adhesions, the adhesions anchoring the fibroid to the uterine wall. فطبعا you know these all vessels here. You can see this is the uterus, this is the inner myometrial wall. Sometimes we may even open the endometrium, so we have to لازم نبلغ المريضة إنه if the endometrium was opened during surgery. This is a laparoscopic view of multiple uterine fibroids. Complications of myomectomy: there may be a hysterectomy, which is due to a bleeding to the uterine wall, and later on a mental and intestinal adhesions. And as I mentioned, the fibroids may remove because there may be intramural fibroids that cannot be removed, or submucosal fibroids. There is a recurrence rate, a risk of preterm labor and rupture scar during next pregnancy. تمام. أحد عنده سؤال عن myomectomy؟ Gynecological operation is hysterectomy, which is removal of the uterus. Hysterectomy, we decide upon the type of the hysterectomy according to the condition of the patient. In patients, for example, with accreta, placenta accreta, she's a 20-year-old lady or 25-year-old lady with previous 2 cesarean and now presented with placenta accreta. Which type of hysterectomy do you think I will choose or I will do during surgery, during cesarean? And why?
Superficial.
يعني شنو قصدك superficial؟ قصدك هذا؟
نعم دكتورة.
supracervical اللي هو طبعا الاسم الثاني له subtotal. Why do I preserve the ovaries?
دكتورة ليش تدخلها بمينوبوز وهي بعدها يعني؟
Very good. Thank you very much. She's so young. She's young. طبعا مع ذلك those ladies who have a hysterectomy with preservation of the ovaries, they will have a menopause earlier than others. But still, I want to keep her several years with the estrogen progesterone produced in order to protect her from the problems of menopause, starting from the hot flushes, from the intellectual problems, from the up to the cardiovascular and bony problems. Okay, if so, and also in cases of an accurate placenta adherence, I cannot remove the cervix because the problem is here. Sorry, I need to remove the cervix, so I will choose for a total hysterectomy with preservation of the ovaries because the problem, so placenta previa or accurata, is in this area. So if I don't remove it, I will go and the bleeding will persist. Patients who are advised to have a hysterectomy with bilateral salpingo-oophorectomy are those who have, for example, multiple uterine fibroids or hyperplasia at the age of above 45. It is not advisable to preserve the ovaries above the age of 45. It is advisable to do a total abdominal hysterectomy with bilateral salpingo-oophorectomy in order to get rid of the risk of any ovarian malignancy in the future. Because if she has, for example, a genetic problem that leads to an endometrial cancer or any tumor formation, she may have the same potential to develop ovarian tumors. And the surgery will be difficult because of the adhesions from removal of the uterus. We counsel the patient and we advise her, but at the, يعني بالأخير هي الpatient هي اللي تقرر، إحنا اللي علينا ننصح. When do you think we need a radical hysterectomy?
بحالات المالجنسي؟
Yes, very good. In cases of CA cervix, CA endometrium, adenocarcinoma, and CA ovary, it is advisable to do a radical hysterectomy where we remove, sorry, طبعا هي picture should be this one. It is removed يعني fully with the ovaries, with the tubes, and even the parametrium from both sides, and an upper cuff of the vagina is removed in case of lateral radical hysterectomy اللي هو الvertine hysterectomy, and also we search for lymph nodes, we take them and we biopsy them. طالع الفيديو يمكم؟
أنا يمي بعدها على types of hysterectomy.
تمام. لا أرجع على هذا.
هسه تمام يا دكتور.
Here you can see that a hysterectomy, we can do it in 3 ways. It can be done through a laparotomy, it can be done through a laparoscopy, or it can be done vaginally, a vaginal hysterectomy. The vaginal hysterectomy is a very nice procedure. The patient will feel the pain is much better than an abdominal hysterectomy because the absence of the abdominal wall incision. And this also a laparoscopic hysterectomy is also associated with less pain, faster recovery, faster return to home and to work and activities. Mostly through abdominal hysterectomy, it is reached through a finished teal incision. Sometimes in a few cases, especially in cases of malignancies or in very large masses, we may need a midline incision. Here you can see a finished teal incision is done, and then separation of the abdominal wall layers, separation of the rectus muscle and the parietal peritone. Here is the uterus. This is the right side. This is the left side. We will start by dividing the pedicles. Here we will start by dividing the pedicles, starting from the round ligament and then going to the round ligament on both sides. أحد يعرف شنو شغلة الround ligament? Is it a support for the uterus, or does it have a different function? The round ligament is not sorry حد يجاوب؟
دكتورة الراوند ليجمنت مو كان بيهم ارتري arterial supply قريب منه؟
لا هذيك البرود ligament.
تمام.
الراوند ligament شغلتها تبقى اليوترس in anti-version anti-flexion. If the round ligament is loose enough, the uterus is retroverted. So we start by dividing the round ligament, and then we go to the pedicles one by one. I'll show you in different slides. Let's just watch the video. So we divide the infundibulopelvic ligament, and then the uterine artery, and finally we divide the uterus, and it is removed through a hysterectomy. طبعا الفيديو مبين حياة كلش سعيدة وسهلة. Sometimes we need to do a vaginal hysterectomy where the uterus, especially in cases of procedentia, and can be done also in cases of mild degree of prolapse, but the uterus is not large in size, and it can be removed vaginally. زين. As I said, it can be due through a phalangeal incision or a midline, but here the phalangeal is more acceptable cosmetically and a better healing, less risk of incisional hernia. What are the steps? We start first with the infundibular, as I mentioned, the round ligament. Here are the round ligaments, as you can see. Round ligament, it is cut and we sutured them. It has a small vessel, but it is not, it's just to supply the round ligament. It is not associated with, it does not supply the uterus. And then we go to the infundibulopelvic ligament. If I want to preserve the ovaries, I will cut and ligate from this side. As you can see, the ovaries and the tubes will be preserved. However, if I want to remove the ovaries and the tube, I will put my clamp here so that the incision will go through this area, and removal of the infundibulopelvic ligament with the tube and the ovary is done. Here you can see هذا sheet here, the broad ligament. Then also has vessels, and here is the bladder. The next step is removal of the uterine artery. After cutting and ligating the round ligament, the infundibulopelvic ligament, I will come to cut and ligate the uterine artery. However, I have to be careful in this procedure. Why? I have to be very careful. What complication may happen?
Injuring the ureter.
Yes. شو اسمها المقولة المشهورة على اليوريتر وعلاقته باليوتراين artery?
Water under the bridge.
Yes, it's very, very near, very near. It's approximately يعني sometimes even less than 2 centimeters. That's why I have to be very careful when clamping the uterine artery and cutting it. And if I'm in suspicion that I may have injured the ureter, I will ask for the urological surgeon to come and check the ureter with me to make sure that I haven't ligated it mistakenly or cut it during removal, during uterine artery ligation. طبعا وهذا كلش مهم in cases of acrita, in placenta acrita, because of the invasion of the trophoblastic tissue in the surrounding area that may distort the normal anatomy. فتشوفون بالأكريتا هواية مرات احنا نشتغل ونخلص ونشيل اليوترس، مع ذلك ندز على الاختصاص البولية to check the bladder, especially in cases of pericrita where there's invasion of the bladder, and also to check that the ureter is intact. After the uterine artery, there will be downward reflection of the bladder. أبدي أنزل أوخر I remove any attachment of the uterus to the surrounding tissue. So here I will dissect this peritoneal fold. Sorry, this is the posterior wall طبعا. Here is the anterior part where you can see that the bladder is downward reflected. Now here is the posterior wall where there will be downward reflection of the uterosacral ligament. So I will end with a picture that is just like this. Here you can see that the uterus now doesn't have only the macronode ligaments. I have removed all the pedicles attaching the uterus. I have removed the anterior and posterior peritone. So here now is the lower uterine segment and the cervix that is attached only by the pubocervical ligament, macronode ligament. So I will clamp it, a clamp placed on the cardinal ligament or macronode ligament or pubocervical, and I cut it. راح يبقى عندنا بس attachment of the uterus to the vagina. It is easily removed. يعني زين, why should I clamp and ligate and secure the cardinal ligament رغم انه it does not have a blood vessel؟ ليش؟ كلش مهم وكلش ادير بالي بشغلي من اوصل للماكنرود or cardinal ligament. اذا ما اخذها زين شي يصير؟ يصير vault prolapse. احنا مو راح تبقى الفاجينا وراح يعني I will secure the upper edge of the vagina اللي هو اللي حنسميه vault. If I don't support it well during surgery, I will end with a vault prolapse, and which will need management because إذا الvault نزل ممكن يجر ويا البلادر والureters وتصير عندها voiding difficulty. Here you can see images of the uterus. This is the uterus. These are small fibroids. Here is the infundibulopelvic ligament with the ovaries. هذا ovary وهذا ovary ثاني. The ovaries are posterior. As you can see, the cervix is removed completely. هنا تشوفون مشيور parametrial tissue. Or in these cases, probably be in cases of endometrial cancer. If this parametrial tissue is not present, it's just a simple hysterectomy. In cases of vaginal hysterectomy, it is done for women with prosidentia. هي طبعا نفس الهستركتومي بالضبط بس الخطوات بالمقلوبي. يعني اللي حبتي بيه هي الماكنود ليجمنت وراها اليوتراين ارتري وراها infundibulopelvic والround ligament. So as you can see, here is a prosidentia where the uterus has prolapsed through the vagina, and they are injecting normal saline with adrenaline to create a bloodless field during surgery. They injected in the at the size of separation. Then, and we start gradually. Here they divided the macronode ligament. Then, and وشوي شوي يصعدون to divide the infundibulopelvic ligament on both sides. Here is the right side and here is the left side. فما راح يبقى آخر شيء round ligament and the uterus will come easily. And then we will close the defect that happens. We will try to secure the vault so that she does not have a vault prolapse. It's a very nice surgery. The patient is very satisfied because the pain is much less. However, we cannot do it for cases of suspected malignancy. And we cannot do it for cases where the uterus is large, especially the size is more than 12 weeks, because it cannot come out through the vagina. And also we cannot do it for patients who have had multiple surgeries before, and we expect that many intra-abdominal adhesions are present. To help us with this, we can use laparoscopy to divide these adhesions and continue with the hysterectomy. So what are the indications of hysterectomy? Why do we want to do a hysterectomy? سولفوا لي.
دكتورة أول سلايد بعدها علم الفاجينال هيستريكتومي.
يعني اوكي هسه هذا كان هو هذا تمام؟
اي تمام.
زين. Sorry. What are the indications of hysterectomy? Whether يعني abdominal, vaginal, laparoscopic. يعني abdominal laparotomy, laparoscopic تقريبا نفس الشيء.
Prolapse.
Very good. Thank you.
Malignancy.
Yes. أحد ثاني؟ حيدر هو أنت كنت مو تمام؟ لو منو؟
أنا عبد الله دكتور.
عبد الله سوري. عبد الله أنت بعد عندك أفكار؟
Abnormal uterine bleeding.
For what? يعني which cause for abnormal uterine bleeding?
Malignancy.
Good. Adenomyosis, hyperplasia. زين بالاندومتريوسس شنو نوع الهستركتومي لازم يكون؟
يعني hysterectomy و salpingo-oophorectomy يعني وياها؟
Yes, very good. Because the problem is in the ovaries. I need to remove the source of estrogen and progesterone so that any endometriotic deposits will gradually degenerate. So as you can see, for any suspected malignancies, myomas, endometriosis, probably dysfunctional uterine bleeding that is not responding to treatment, and sometimes I may go for a subtotal hysterectomy if the patient wants to preserve her cervix, especially if she has read that that it is it won't affect her sexual life with her husband. What important point should be ensured prior to a subtotal hysterectomy? أكثر نقطة كلش مهمة لازم أسويها before I go for a subtotal hysterectomy.
pap smear.
Very good. يعني أنت عبارة عن consultant obstetrics and gynecology عبد الله. زين. يعني if the pap smear is normal, okay, let's go for subtotal hysterectomy, and you have to do the routine follow-up. You have to go with the recommended schedule for follow-up of the cervix with the pap smear. However, if the pap smear shows a cervical intraepithelial neoplasia, actually, I won't advise so much for a subtotal hysterectomy unless the patient insists on the subtotal hysterectomy and confirms that she will have a regular follow-up for her cervix. As I mentioned, after the age of 45 and after menopause, it is preferable to do a total abdominal hysterectomy with bilateral salpingo-oophorectomy to minimize the risk of any ovarian malignancy that is difficult to be managed surgically later on because of adhesions. For younger ladies, no, as we mentioned, we try to preserve the ovaries unless she has a family history of CA cervix or CA endometrium or CA breast. What complications may happen during hysterectomy? We may have anesthetic complications, even requiring RCU admission. We may have uncontrollable bleeding. There may be injury, as you know, to the surrounding structure. We may injure the bladder, and it is not a big deal to do an injury during surgery. The bladder may be opened if there are adhesions. The ureter may be ligated if the case is a CA cervix that with the fibrosis. The bowel may be injured if this injury is not detected during surgery. احنا من نوقع مريض على كونسنت مال عمليه، هو دا يوقع على العمليه والريسك مالتها الكومبليكيشنز، but هو ما دا يوقع على الميديكال errors or medical fault of not detecting these complications. يعني اذا اني مثلا during reflection of the bladder وصار injury to the bladder, it's not a big problem. It happens with anyone because of the probably adhesions, the thin wall of the bladder. تمام، أنا شكيت إنه أكو injury، I will fill the bladder with the normal saline. I will detect for a leak, look for a leak. If there's a leak, I will correct it. إذا medical legally هو ما بيها يعني repair of the bladder is an easy procedure. But sometimes medical legally, in this, we send for the urological surgeon to see that we have done it correctly, or for them to do it instead of us. The problem arises if I don't detect the bladder injury. فمن راح نخلص الهستركتومي, we will close the abdominal wall أو نطلع laparoscopic instruments. وراها ونخلي طبعا درين للمريضة. وراها شو يبدي يطلع الدرين؟ يبدي يطلع يورين. يظل الدرين مالتنا يوميا ترس 500 cc ادزه هذا تحليل هذا يورين. Here is the problem. The patient may have a right to file a complaint against you because that is a medical error. There is a risk of bladder injury, but you didn't detect it during surgery. نفس الشيء عقدة اليوريتر، نفس الشيء الباول injury. صارت مثلا هنا أنا عندي bowel adherent I did adhesive lysis and there was injury to the bowel. Oh, that's not a problem. ندز على أهل الجراحة يسوون correction، نخلي البيشنت in by mouth and يعني الحياة سعيدة للبيشنت and for us. However, if I don't detect the bowel injury, what will happen? شو يصير if I don't detect a bowel injury during hysterectomy?
bowel leak sepsis.
Very good. Fecal peritonitis and sepsis. And this is a medical error. I may lose my patient. DVT and pulmonary embolism, that's why I need to cover the patients with anticoagulants 5 to 6 hours after surgery. أحد عنده سؤال على hysterectomy؟ Another common gynecological procedure is laparoscopy, where we visualize the abdominal cavity after filling pelvic and abdominal cavity after filling the abdomen with the CO2 gas. First, we introduce a Veress needle through the umbilicus, and then we introduce the camera. After that, we will look we introduce the Veress needle and we will inflate with the CO2. Then we introduce the camera and we will look around. ليش؟ لأن أنا أريد أدخل ports بعد حسب طبعا وين أنا أريد أشتغل، بس أكثر شيء بالرايت ولفت iliac fossa. So I will look with the camera when I introduce the probes in order to avoid injuring the bowel or injuring the bladder, and also to see if there is any probably injury to a vessel in the abdominal wall. And then I will start doing the procedure of يعني laparoscopic procedure اللي بالي يعني خلال الشغل اللي هو طبعا ممكن يكون diagnostic laparoscopy which is done mostly for patients with suspected ectopic اللي هو طبعا راح ينتهي therapeutic provided that there's no contraindication. Laparoscopy can be done for patients with for example diagnostic laparoscopy for patients with infertility in order to detect tubal patency and also to see if there is any problem. I had a patient who had primary infertility 3 years. We did a hysterosalpingiogram for her and the tubes were blocked from the cornea. The hysterosalpingiogram. Upon laparoscopy, it was actually discovered that the patient congenitally had absent tubes. Both tubes are absent, but there is a uterus and there are ovaries. Can this patient get pregnant? يعني عندها uterus عندها ovaries بس ما عندها fallopian tubes.
IVF لازم.
Yes, very good. IVF وحتى هنا حتى الريسك مال ectopic هم تروح من عندها لأنه she does not have tubes. So the indications, as I mentioned, could be diagnostic or therapeutic. For example, if the patient has acute or chronic pelvic pain, we'll do it diagnostically. طبعا أغلب اللي عندهم chronic pelvic pain يطلعون cases of endometriosis or sometimes pelvic inflammatory disease. We can do it for patients with pelvic inflammatory disease. مرات البرزنتيشن مالتهم يجي يعني query. تيجي patient بالcall عندها فد right iliac fossa pain. She does not have any adnexial mass. However, she may يعني during laparoscopy اللي هو ما عندنا بالcall, but يعني if the patient is vitally stable تبقى لحد ما نعطيها موعد laparoscopy, we discover that she may have endometriosis, she may have a pelvic inflammatory disease, she may have pelvic TB. زين for cases of hysterectomy, myomectomy, even for malignancies now laparoscopy is used to manage malignancies with a full staging during laparoscopic procedure. The contraindications, as you all know, if the patient is unstable vitally unstable. يعني أنا تجيني اكتوبيك الصبح وعندي صالة مال لابروسكوب موجودة بس البulse rate مالتها 120. She is pale, she is sweaty, there is fluid in the abdominal cavity. I won't go for a laparoscopy because the time to prepare the patient I may lose خلال هاي الفترة I may lose my patient. At the same time I want to stop the bleeder, so I will go, it is faster for me to go to do a laparotomy. If the patient is very obese, if the patient has a diaphragmatic hernia, if there's peritonitis, if she has had multiple مثلا 4-5 سيزارينات قبل, previous 5, previous 6 cesarean وهسه عندها ovarian cyst, it is difficult to do a laparoscopy for her. I may go with a laparoscope, يعني أقولها أنا راح أدخل باللابروسكوب وإذا ما شفت adhesion راح أسير السيست. أما إذا شفت adhesion and I cannot do my work, I will go for a laparotomy. أطلع الانسترومنتس، أفرغ الغاز and I'll go for a laparotomy. The complications, as يعني just any surgical procedure, injury to the surrounding structures with anesthetic complications. And later on المشكلة تصير إنه إذا unrecognized visceral or vascular injury لأنه من الفيلد مفتوح كله قدامنا مو مثل من الفيلد is looked through a camera through 3 tiny openings. Port site hernia, there may be a vascular injury تنتهي المريضة بشوك because of injury of which vessel in the abdominal wall اللي يكون significant enough if it is injured that it will cause shock. And it may be missed during surgery.
اليوتراين ارتري نفسه؟
لا بالابدومينال وول عبد الله.
الرينال ارتريز؟
لا inferior epigastric artery بالابدومينال wall. If I miss it will يعني هو يكون فد lumen مالته يعني not so big but not so small that it may even يعني the patient may end with shock. Another minimally invasive gynecological هذا طبعا laparoscopy. Here you can see laparoscopic images of the uterus. طبعا احنا إذا تتخيلون احنا we are looking through the umbilicus, so this is the posterior wall of the uterus. Here are the ovaries and these are the tubes. Here drilling is done for the ovaries in cases of polycystic ovaries. As you can see, 4 holes are in order to reduce the polycystic condition state of the ovaries. Here is excision of a hemorrhagic cyst, sorry, or a chocolate cyst of the ovary laparoscopically. Here is removal of a simple cyst. شوفون شلون هو cyst wall فراح يبقى ال wall of the ovary and it will be sutured and closed ويرجع الأوفري يعني مثل ما كان. Another minimally invasive procedure is hysteroscopy.
In your uterus, of your uterus.
Here you can see by hysteroscopy a speculum is introduced. Dilatation of يعني we hold the anterior lip of the cervix with a vollicellum. Dilatation of the cervix, you can see that the dilators we start with the thinnest up to the largest in order to طبعا نحتاج الدايليتر الكبير لأنه to introduce the instruments of hysteroscopy. Now a camera with a light source is introduced to inspect the uterine cavity. And هذا كل uterine cavity. Here is the left tubal ostium, and from the other side, the right. We look for any lesions in the endometrial cavity. إذا بس diagnostic خلاص يعني ماكو مشكلة وأطلع. إذا therapeutic أكو يعني هذه مثلا polyp هذاك التubal ostium. Here you can see a resectoscope to remove the polyp. Sometimes we may do endometrial ablation. مثلا simple hyperplasia without aspia. I can go for endometrial ablation of the endometrial cavity. The indications when if she has abnormal menstruation, in order to take a biopsy and to detect any polyp into a submucosal fibroid. If she has any abnormal bleeding, postcoital bleeding, intermenstrual, postmenopausal bleeding, I can offer an outpatient hysteroscope diagnostic. if I suspect something مثلا أنا مسويت لها ultrasound اللي هو saline infusion sonography وأكو lesion in the cavity, I can go for it immediately. مكان diagnostic ومكان outpatient أخذها للصالة وأسوي لها يعني therapeutic hysteroscope to remove any lesion. In cases of subfertility, to look if there is something blocking the tubes, recurrent miscarriage, there may be a uterine anomaly, مثلا septum, and I resect it with a resectoscope. In Asherman syndrome, to remove the synecdoche or the adhesions, congenital uterine anomaly, as I mentioned, and there is a missed intrauterine device with lost thread to remove. يعني in order to remove that thread. Complications that may happen. طبعا contraindications in cases of CA, pregnancy, heavy bleeding, the patient is vitally unstable, and cases of PID. What complications I may anticipate? I may perforate the uterine wall during surgery or during treatment. For example, when I remove البوليب سهل حلو يكون pedunculated. However, myomas, there may be flush. البيديكل مالتها مو كلش واضحه, maybe flush with uterine wall. فأنا شنو من حنبتي نشتغل خصوصا إذا سمي mucosal fibroid كبير. We will start with piecemeal removal of it, and then when I reach to the wall of the uterus, I have to make sure إنه لا أبقي من الفايبرويد شيء ولا آخذ شيء زايد من الوall وأنتهي perforation. Bleeding, gas embolism, يعني injury to the cervix and to the uterus. Late complications هو there يعني any like the complications from procedures done in the endometrial cavity اللي هو يصير Asherman syndrome, infection, bleeding, and so on. Here, the slide shows a synecdoche or a septum, sorry, a septum. This is the left and this is the right part of the cavity. هنا بالريسكتوسكوب يعني نبقى مثل نقشره بالضبط, يعني يتقشر تقشير يعني part by part, piece by piece, until we reach an adequate depth إنه أني ما أسوي perforation بس بنفس الوقت أشيل السبتم. Here, as you can see, these are the normal يعني tubal ostia. Thank you very much. يعني أحد عنده سؤال؟
دكتورة بس بالنسبة للفايبرويد قلنا نستخدم بيهن GnRH اجونست بوقتها.
نعم.
ممكن نستخدم. زين دكتورة, هو شو راح يفيدنا الGnRH اجونست؟ يعني يقلل
يقلل البيتويتري, يسوي نيجاتيف فيدباك وداون ريجوليشن مال البيتويتري. ف ماكو استروجين بروجستيرون, فيقل حجم الفايبرويد. يعني كلش طبعا انت given for only 6 months, يعني 6 اشهر. ممكن اكو انترانيزل سبراي, ممكن اكو اوبرا شهريه اللي يعني موجوده طبعا بالمستشفى, اللي يعني after 6 months there's a problem of irreversible bone loss, واللي هاي طبعا هم حيصير عندهم menopausal side effects. فخلال ال6 اشهر I'm creating a pseudomenopause, فراح the fibroids will decrease in size. فمثلا هي عمرها مثلا 30 وعندها بس بيبي واحد, وهي هيجي fibroids, she has a very high risk of having hysterectomy. So we يعني by counseling نصغر حجم الفايبرويد, بس راح تطلع لنا مشكله انه الديماركيشن الكبسول تصير تنخلط ويا المايومتريوم. طبعا ورا 6 شهور يرجع يكبر حجم الفايبرويد اذا ما صارت مينوبوز.
تمام دكتور.